Hello everyone, and welcome to our webinar this afternoon. Today's topic is Improving SOAR Applications with the Essentials of Trauma-Informed Care. Today's webinar is presented by the SAMHSA SOAR Technical Assistance Center at Policy Research Associates under contract to the Substance Abuse and Mental Health Services Administration of the U.S. Department of Health and Human Services. My name is Pam Hine, Senior Project Associate of the SOAR TA Center, and I will be moderating today's event. A quick disclaimer, we need to remind you that this training is supported by the Substance Abuse and Mental Health Services Administration and the U.S. Department of Health and Human Services. The content of this presentation do not necessarily reflect the views or policies of SAMHSA or DHHS. Just a couple of webinar instructions before we begin. Your lines will be muted throughout the webinar. This webinar is being recorded and will be available for download on the SOAR website in about a week. You may download the PowerPoint slides and a couple of handouts by going to the SOAR website and click Webinar, and you will see the slides and two handouts that you can download now. Right after the webinar, there is a quick evaluation you'll be directed to. We really appreciate your feedback, which informs future webinars. So we really encourage you to take the brief evaluation. And finally, we will save all questions until the end of the presentations, and we'll review instructions for asking questions via the Q&A function at that point. Just a couple of learning objectives. It is our intention that by the end of this webinar, you will increase your awareness of trauma and its impact, and also learn how to integrate trauma-informed principles when providing SOAR services within a variety of settings, which include justice-involved, veteran, youth, home shelters, domestic violence, and also mental health settings, and also applying trauma-informed principles to gather a thorough history and greater amount of information in a way which minimizes re-traumatization. And we'll also briefly touch on SSA's new mental disorder listing, 12.15, for trauma and stressor-related disorders. So we'll talk a little bit about that. So the agenda this afternoon, you'll hear from Dr. Lisa Callahan, Senior Research Associate here at SAMHSA's Gain Center. Next, you'll hear from Kim Davison, Director of Clinical Services at Debras Place in Chicago. Kim will talk about the 10 principles of trauma-informed care. And then you'll hear from Miletti Marsh, who is a SOAR case manager at Deborahs Place, who will share a few SOAR vignettes about how she's been able to apply trauma-informed care principles to the SOAR applicants she works with. And then, as I said, I'll touch on the new trauma listing as well.
Let's start.
Yep. So now I'm going to hand it over to Dr. Callahan, who will talk about what does it mean to be trauma-informed.
Good, everybody. Thank you for inviting me to do this presentation today. What I'm talking about is generally what SAMHSA has been lead on in terms of incorporating trauma-informed practices into all of their programs and technical assistance centers, and also to give you some just some broad brushstrokes in terms of how trauma and the trauma experiences of people who you come into contact with by being a SOAR provider will change your practices if you put this in the forefront of your approach to people you're working with. Also, I want to just put as a footnote here, too, is one of the areas that we won't have much time to talk about today, but it's something I'd like you to keep in mind, is the importance of not only thinking about the trauma experiences of people you're working with in terms of the clients that you're working with, but also your coworkers, because various trauma and primary trauma is certainly a high risk for people who work with individuals who are at risk for homelessness, at risk for justice involvement, people with mental health disorders. So keeping in mind this applies not just to the people that you're working with in terms of doing SOAR work, but also your coworkers. we certainly have a lot of inquiries, and there's a lot of interest in knowing and learning more about trauma. And depending upon which field you're in, the actual specific reasons are going to differ. But there really are three global or national reasons why trauma has become really part of the conversation in many social service systems. One is the science has changed dramatically around what we know about the brain. I'll talk about this a little bit more later on, but we know that exposure to trauma, and this not necessarily, but it also includes physical trauma, but emotional trauma, we know that it can have an impact on the brain and on brain development. We also, through our work, have observed that trauma has a significant impact on adults. Those of you who are in direct practice, I'm sure you see this on a regular basis. We also know that untreated trauma has a pretty significant cost to our social systems, whether it's the legal system, medical system, our social networks. It not only causes sometimes a waste of resources, but it also, through re-traumatizing people, often leads them into more and more deeper involvement in the various social systems. Well, that's a somewhat, perhaps we shouldn't talk about money all the time, but it really is, it does have a financial cost to the systems. And finally, politics. Depending upon, as I said, depending upon what area you work in, there's been a movement nationally, it's called Raise the Age, and that's to make the age of legal responsibility, raising it to 18 or above. There's a few states who still have it at 16, which happens to be New York is one of them. That's one of the reasons why we're really paying attention to the impact of trauma on the brain, but also, and probably an area that most of us are very familiar with, is the acknowledgement that our soldiers who've been returning from deployment in the most recent wars have really had a lot of difficulty and a lot of concerns about suicide, high suicide rates among soldiers. So it really has forced us to address the impact of trauma and how we can better address it. So let's now about what is trauma. I'm not going to read this slide to you, but I would like to point out to you the three words that are highlighted: event, experience, and effects. These are what we refer to as the three E's. Many times as I've read this definition, I couldn't cite it to you, but I do think the easiest way to think about this is that individual trauma is an event, but that isn't what makes it a traumatic event. What makes something a trauma is the way in which someone experiences and the effect that it has on a person's functioning. This is important to keep in mind because sometimes, if we're more resilient than others, we might be surprised or perhaps even in our minds critical why someone seems to be stuck in something that happened to them a week ago, a year ago, or a decade ago. And what we know about trauma is that there is no expiration date. If an event has had a traumatic effect on someone, it stays with them, and the way in which they go forward depends upon a lot of factors, both individual and social factors. So what I want to make sure that we always keep in mind is that our resilient selves are not necessarily shouldn't be the standard against which we're judging other people's reactions to things that have happened to them or events that they're living through right now. We'll get back to this definition as we go along. So here are some examples of traumatic events in a general sense. There is intentional trauma, unintentional trauma, and then types of trauma, which often we find are a little harder to dig deeply into. I think we all can understand why different kinds of abuse, different kinds of violence would be considered trauma. And certainly those of us who've experienced the loss of a loved one, especially when it's sudden, or injury that we or someone close to us has experienced, would understand why that is a trauma. Unintentional, but a trauma nonetheless. But the last grouping here, other types of trauma, historical trauma, vicarious trauma, these are all just as potentially toxic to someone as something that was done intentionally to them. Example of historical trauma and the importance of understanding it would be the kinds of experiences that people who are refugees experience. Their loss of homeland, they're moving to a new culture, their lack of safety in their new home. We know we have many examples historically from that. We certainly have some in contemporary terms as well. There are community traumas that occur, whether it's a natural disaster like a hurricane, a fire, 9/11, that everyone living in the community experienced to some degree. And I mentioned vicarious trauma before, and I'll want you to keep this in mind. Vicarious trauma is that trauma that you don't experience directly, but through your work with people who have had direct experiences with trauma, it begins to have the same kind of effect on you. And so people who are in direct service, emergency service workers, anyone working in an emergency room, really are at high risk for vicarious trauma. So it's something certainly to keep in mind, the type of work that all of you do. I mentioned earlier that trauma affects the brain, and I am not a brain scientist. I don't even play one on television, but we do know that trauma affects the brain, and I think if we even dig back a little bit into some of our own experiences, we know that in times when we're under just intense stress, our systems shut down, and often what shuts down is our good judgment. When I do trauma training, I refer to it as the lizard brain kicks in, and that really is our preservation brain, not our thinking, logical brain, which is what we tend to use most of the time, and I refer to that as the wizard brain. But when we're under a lot of stress, when our brain is being flooded with stress hormones, our lizard brain kicks in, and we often don't make the best judgment. So for people who are either living in current traumatic situations or have had numerous traumatic events over their past, their brain has been really flooded with stress hormones, which alters the course of their ability to make the kind of judgments that we imagine they should be, or many of us wish we could. Also here, I won't go to it because we don't really have time here, but traumatic brain injury and PTSD overlap. Some of the symptoms are similar in which you would be observing, such as attention problems, sleep problems, difficulty controlling anger. But TBI and PTSD are different phenomena, and someone who suffered a traumatic brain injury is more likely to have physical somatic ailments such as headaches, ringing in the ears, nausea, dizziness, whereas people who have PTSD are more likely to have more psychological effects such as flashbacks and nightmares and being startled easily. So there's overlap. Is something just to keep in mind, but they are two distinctive phenomena that are going on in the brain, and certainly someone with a traumatic brain injury also can have PTSD. The exposure to trauma and traumatic events can have a long-term effect, and when you look at this five-pointed, I guess it's a pentagon here, the way to think about this is the external factors, physical health issues going clockwise, mental health issues, behavioral issues, poor relationships, substance abuse. Those are what we see. Those are the observable outcomes of trauma. What we don't see is what is underlying that, and that's the fear and powerlessness that someone often develops if they've experienced trauma, the sense of anger, the sense of pain, both physical and emotional pain. And so we don't see those emotions, but we just see the manifestations of those often through, that's why they come to see you, that they have mental health problems or that they have behavioral problems such as justice involvement, or that they are unable to remain housed and so they're constantly experiencing risk for homelessness. That's what we see, but what's underlying it are really the psychological effects of trauma. Just quickly, this slide is I guess, if there's a take-home message, this is it. The trauma really is pervasive. And with populations that you're working with, what I would suggest is that you always go in with the assumption that there's trauma. And it's nothing to be lost by doing that. It's a way of approaching people, which we'll talk about in a little bit, but it's a way of approaching people of being trauma-informed with the intention of not traumatizing them. We don't know what nightmare they lived through the day before. We don't know difficulties they had coming to see us today. We don't know what riding public transportation might trigger into their experiences. So keeping in mind that trauma is practically universal with some of the populations that you're working with is really a safe assumption and a really a mindset to go into interactions with. Oops, right in here, okay. There. Most of you probably heard of the Adverse Childhood Experiences Study. It's referred to as the ACEs. It was originally conducted in California by Kaiser Permanente, which is a healthcare provider. It currently has been taken over by the Centers for Disease Control. And the 5 items you see listed here, from physical abuse down to witnessing domestic violence, are considered the ACEs. These are events that adults over the age of 18 endorse happen to them when they were a child or not. And I don't want us to take too much time with this, but what this does indicate is that with this is the general population, that many people in the population have experienced at least one, if not and more than one ACE. Now, this is the general population. For populations that you're coming into contact with through your work, this population, or the ACE experience is much, much higher. Just to give you one example, one of the research studies that I did was with youth who are in a specialty court in one representative county in the United States. I'm not going to name it, but we administered the ACE to them, and the average age of these children was 15, and half of them had experienced at least 5 ACEs by the time they were 15. Now, these are all court-involved children, all of whom have a mental health or substance abuse disorder, and so if you have contact with any specialty populations, the likelihood that they've experienced many more ACEs than the average adult is quite high. There's also some you may have seen some that have additional ACEs. Those are all add-ons, and there certainly is a wealth of information about them. If you would like more information, I can give you those references. Okay. There we go. One of the areas that the research is very, very clear on is that, as we said, the more ACEs someone has, the more likely they are going to develop physical health problems as an adult. And without exception, every poor outcome, I think most of us would agree that this entire list here are outcomes none of us would want. Each of these physical health outcomes is directly related to the number of ACEs adults experienced as a child, without exception. These are all statistically significant. Some of these, so one of the messages is that if you have people who you're working with who have 1 or 2 of these, chances are they may have 5 or 6 of these health problems as well. It's multiplicative, it's not just additive. This is true with substance abuse and mental health issues and trauma. People who experience ACEs, the more ACEs you experience as a child, it significantly increases the risk for all of these mental health and substance use outcomes as well. Many of these are overlapping. If there are terms on here you don't understand, certainly send a message to us, ask the question. But these are all diagnostic categories that have been observed in people who have higher rates of ACEs as children than others. This is also true with people who become involved in the criminal justice system. For ACEs, someone experiences as a child, the more likely they're going to be arrested in adulthood. The more likely they're going to experience depression, anxiety, substance use disorders, as the last slide said, which often gets them into trouble with the criminal justice system, and other behavioral outcomes such as domestic violence, again, gets them into contact with the criminal justice system. So this isn't, I don't want to leave this by sort of having a sort of a fatal view of that. But I think what's important to keep in mind is that as you're working with people, if you learn that they have experienced a number of these childhood risks, if you will, they may not be revealing to you in the course of your interaction all of the other experiences that they've had, but something to keep in mind. It may be something that evolves over time. One thing we know for people who've experienced a lot of trauma, they feel safe and certainly don't feel emotionally safe with revealing information to people, certainly people they've just met. Oftentimes it's people who work with people with trauma, a lot of trauma, it's 6 months to a year before they reveal what actually happened to them earlier in their life. So it may be buried deep in there. So if you see a lot of somatic problems, if you see a lot of behavioral problems, you may want to pay close attention to their trauma history and may want to refer them quickly to someone who specializes in trauma-informed care. I'm going to the point of trauma is pervasive. We know that in the National Comorbidity Study, which is a representative sample of adults across the United States, more than half of men and women report at least one traumatic event. In Detroit, and this was before the problem in Detroit, I would argue that if you were a parent living in Detroit in the last year, every one of those parents has experienced a trauma, being concerned about their child being exposed to toxic water. So it isn't geographically equally distributed. There are certain communities, certain neighborhoods that have higher rates of trauma than others, environmental and other trauma. To focus just for a second on PTSD, most people who experience trauma will not develop PTSD. One person who goes to war is exposed to trauma. Only around 20, and I don't mean only, but about 20% of soldiers develop PTSD over the course of their lifetime, so in an average. I break it out a little bit here with regard to previous wars. We have more to say about Vietnam-era veterans because it's longer since we've been out of the Vietnam War. So think about the prior slide that over half of men and women have experienced trauma, but only 10% of women develop PTSD and 4% of men. I think you'll understand sort of the proportions there. It's something to keep in mind. That's just general population. For veterans, other factors that affect whether or not they'll develop PTSD are listed here. Those include all of the different contexts of the war that they're involved in, where they were, how many deployments they had, other things that happened to them. And one experience that has really come to light in the most recent war that we've been involved in is military sexual trauma. And it's something that we know is a risk factor for men and women who have been in war and have experienced military sexual trauma. It increases their risk for developing PTSD. I just want to circle back to this diagram here so you can think about, again, the different manifestations of trauma that you may see in the course of your work. It may not say trauma, but if you see any of these physical manifestations through various assessments that are done, you should keep a keen eye on whether or not trauma might be underlying some of those problems. That by experiences, how someone has to experience a traumatic event is going by person to person. And we've all had the experience, and maybe within our own homes, where children can grow up in relatively identical circumstances, experience exactly the same events, but the impact that it has on them is different. The effect that it has on them is different. Because of their individual composition, their individualized experiences have led them to a different effect of that event. So it's important to keep that in mind. Things I like to stress here is that some of the factors here which pull people toward resilience or risk, you can change. You can work through as a result of case management, for example. You can't choose someone's parents. I tell my children that all the time. They didn't get to choose their parents. But you can work on primary relationships. You can work on providing meaningful activity for people through providing employment or volunteer work. So you build on those factors that may be risk factors but become resilience factors, and that's really an important part of knowing what dynamic factors are part of an individual's experience and those that are static. Thinking about how to develop a trauma-informed work habit, it is a habit, is to think when we talk about risk, R-I-S-C, specifically think about risk, R-I-S-C reduces risk, R-I-S-K. So that's protecting ourselves in a respectful manner, people with information. Information is free. Bring questions in a way that someone understands, giving a sense of safety, and then giving them choice where possible. Sometimes choice isn't possible. When it is, even though it may seem like a really small choice to you, such as do you want to meet me at 9:30 or 10:30, it may make a huge difference to the person that you're meeting with. And so whenever possible, really have these as sort of guiding principles in the way that you personally conduct yourself. I always talk about we have habits and we have policies. You change your habits. You may not be able to change policies, but you certainly change your own habits around how you conduct yourself and we conduct ourselves in the course of our work. This is really at the heart of what a trauma-informed interaction looks like. It's building trustworthiness. It's doing what we're saying we're going to do, not making promises that we're not willing or able to keep, showing respect, and that's very culturally whether calling someone by, sometimes people think they like to be called by their first name because it's familiar. In some cultures, you never call someone by their first name. So being culturally competent is really important here, and letting someone guide you in terms of how respect can be gained and given. Again, choice, collaborating, really build into choice, and at the heart of kind of trauma-informed interaction is empowering people to be able to be accountable and really in the course of their own lives. So this circles back here to the SAMHSA definition of what trauma is, about any kind of event that you might or believe others might think would be traumatic, asking about that, what their experiences were, and then what the effect of that event or those events were on them. One metaphor that a police officer used with describing a trauma was that it shatters you, and can't reconstruct the same person again. You can reconstruct yourself, but it won't be the same person you were before a traumatic event. And so trauma-informed care then helps people reconstruct that shattered person, narrative and story that they have. So become a trauma-informed organization. I'm going to go over, I know the other speakers are going to speak directly to this, so I will touch on it rather lightly. These are the principles of a trauma-informed approach. This really speaks to your own practice and the policy surrounding your practice. You'll notice that safety is at the top. That is not a coincidence. If someone is not safe, both physically and emotionally safe, in perspective, everything you do isn't really going to matter. If they're always scanning the environment for a way out, for danger, or for something threatening, they're not really paying attention to you or to the work that you're doing. So a trauma-informed approach is being trustworthy and transparent, using peers whenever you can, and I'm assuming there are many people on this call who are themselves peers. I'm a really strong believer in having peers be involved as much as possible in helping gain that sense of safety and participation for people when you're coaxing them into service and into participation and into engagement. I think it's a very valuable resource. Collaboration and mutuality, voice, choice, again, we've talked about that before. And lastly, making sure that not only your language and your policies, but the way in which you even construct the physical presence of your organization, making sure that it is culturally and historically and gender competent. These are the 10 principles of trauma-informed programs, and the next speaker is going to talk about these in detail. I will just take a look at these and we'll focus on them again. Some of the same concepts represented here. And how do you go about, what are the guidelines for implementing these 10 principles? Here, there are 2 slides here that all comprise 10 guidelines. The first is governance and leadership. You need someone to make this their mission, someone who actually has the status and the respect of your peers and coworkers to take this on, that you're going to become a trauma-informed organization. You need to examine your policies. Just as a quick anecdote, when I talk to judges about this, which I do quite often, I ask them how many of them have visited every provider that they require their participants to go to. Some of them have visited. They kind of look sheepish when I ask this question. So I assign it as a field trip. Go and visit every program that you require your participants to go to. And they all like, yeah, they're nodding. That sounds like a good idea. And then I wait, and then I take public transportation to each of those programs, and then you can see the embarrassment on their face. So you need to make sure your policies are doable, that someone can actually accomplish what you're setting out for them. Making sure your physical environment is safe. If someone has a history of sexual assault, they're not going to take a bus at night and walk 3 blocks through a dark parking lot to come to your facility. That is not going to happen. Making sure your physical environment is safe and is responsive. Making sure that you have policies around engagement and involvement, and as I said, using peers is a great way to do that. Making sure that all of the you really use a wide lens who you think your collaborators should be in the community, a very wide lens. Even if you aren't in the justice system or don't have contact with them, your CIT office should be part of your program and should be part of your collaborators. Making sure that you have screening and assessments and treatment services available for people with trauma. I know Pam's going to talk about that at the end, I think. We certainly can provide you at the Gain Center with tools, free and assessment tools that you can use and suggestions for trauma-informed services that you can provide to your participants or clients. Training such as this and other kinds of training and workforce development around trauma. And this not only has to do, as I mentioned at the outset, trauma with regard to your clients, but also your coworkers. You're all doing really, really hard work and are exposed to really difficult life situations, and it's really important that whoever's in charge of your HR understands that and allows for workforce development around dealing with trauma in the course of your work. Making sure that there's, to the extent, these last 3 really go hand in hand, that you have some way to reflect back and look back to make sure that you are working toward the goals that you've set as an organization to become more trauma-informed, and that's obviously through evaluation, and in many cases requires some financing, or a graduate student who needs a master's or doctoral thesis will do it for free, which I always think is a great idea. So I like to condense things down to things I can remember, like the 3 E's. These are the 4 R's in terms of a trauma-informed approach. First of all is realizing the extent, the prevalence of trauma and why it's important to have a trauma-informed approach. Given the populations that you're working with, assume the universal assumption of trauma. Everyone you come into contact with in the course of your work has trauma history. They may be living it today. And unless we're trauma-informed, we're not going to give it the importance and the centerpiece that it needs to have for someone to recover. Recognize how trauma affects everybody. As I mentioned, not just clients, but your workforce as well. Respond effectively and with compassion. We've been more compassionate with our clients than we are with our coworkers, and I think that's something which we all can work on more proactively, and ultimately to resist re-traumatizing people. I don't think anyone goes into any kind of human service field with the intention of re-traumatizing our clients, but sometimes our policies and our habits exactly that. So by turning a lens on the organization, you can really begin to examine how policies, how your workspace, et cetera, how they may in fact be re-traumatizing for people who you come into contact with. And I think that's my last slide.
Okay. Well, thank you so much, Dr. Callahan, for sharing your research and your knowledge on trauma and becoming trauma-informed. The folks on the line, many of whom are SOAR providers, understand that many who enter the homeless service system have experienced violence, loss, and disruptions to important relationships from an early age. And people who lack housing experience a loss of place, as you discussed, safety, stability, and community. And those losses are traumatic, and they require services and responses that are uniquely sensitive to their needs. So this is a great time to hear from Kim Davidson, who's going to talk about how she's able to implement trauma-informed care throughout her agency. So I'm going to hand it off to Kim, who will talk about Deborahs Place.
Thank you. So I'm actually going to start out by just giving everyone a little background on Deborahs Place and who we are and what we do. So we're a supportive housing provider in Chicago, and we provide both permanent and interim housing to our participants, and we do that in both project-based and scat-site apartments, and we serve roughly about 250 women a year. In Chicago, we were one of the first agencies that started adopting harm reduction strategies and making sure that abstinence was not a requirement for our housing, and to also implement some of those housing-first approaches, and have a pretty comprehensive service model, and trauma-informed care is really the anchor that kind of holds it all together. It's a key component of everything we do. And at Deborahs Place, I'm the clinical services director, so I supervise our case managers and our health services staff, and constantly talking to them about how we want to see our participants through trauma-informed lenses. I think of it as like glasses, so if anyone is, like I am, in need of wearing glasses or contacts to navigate the world, we know that when we put them on, we see everything differently. And if we are applying trauma-informed care and all the things that we just learned about to our population, we're recognizing that if we see someone who may lose their temper, storm out of our office, or may have a Social Security application once they started it, if we put on those trauma-informed lenses, we're able to see them through the experiences they've had and what they've been through, and can see everything differently as we move forward. At Deborahs Place, all of our case managers and myself are trained in SOAR as well, and we have done the online training, face-to-face training, and have had a lot of assistance from the TA Center. So I'm going to go through those 6 key principles of a trauma-informed approach, but for each of them, I'm going to talk about some of the strategies that we have used in our SOAR applications at Deborahs Place. So as we already heard, my slide is, as we already heard, safety is really the key principle. If you don't have safety, you really don't have anything else, and we know that, especially for our population, for women who've experienced homelessness, a lot of times their experiences are really dominated by physical and sexual violence on the street. And so when they come in, biggest thing we want to do is make them feel safe, and that's both physical safety, feeling like they have a door that they can lock, and emotional safety, feeling that they can trust the staff. So some of the strategies that we've used when doing SOAR applications are really, and I know this sounds obvious, but building strong, trusting relationships. And these are relationships that aren't just based on, telling people what they want to hear, but instead based on honesty. So when we're helping people with Social Security applications, we need to tell them the good and the bad, that they're going to have to disclose a lot of information about bad days, information about hard days. They're also going to possibly get denied, and this could be a long process. And telling them that we're building these relationships on truth, which allows them to feel safe. We also let our participants do, and interview with whoever they choose. So when I was an administrator in one of our housing programs, we had a participant that wanted to do their MSR with me. And that my role, but that was what we did because we wanted that to feel as safe as possible. We also sit down before we ever do the MSR interview and answer all those questions ourselves. So we are not asking for more information than we might already know. Like sometimes someone has told us something in the past and disclosed a really traumatic story, and we don't need to have to go through that all over again and ask them more questions, possibly triggering them. We ask participants to do the application or interviews in spaces where they feel safe. So that could be their apartment, maybe an office, or maybe a meeting room. We want to be flexible about that. Sit down to do the MSR. We disclose fully all of the things we're going to ask about, and then have a conversation about triggers. How will you know if this is too much for you, and what will you need if you feel overwhelmed? I once did MSR with someone, and we made an agreement that if they felt overwhelmed, they would just get up, and walk out and smoke a cigarette, and that was totally fine. They did that a couple times, and I just asked any questions. I just knew what was happening. Also, normalize breaks and talk about them in the beginning. You're going to need lots of breaks. What do you want to do? So they don't feel like they have to ask for that. Try to give options of things in our staff, their offices with things that could make the experience more comfortable. So all of my staff have candy dishes. My staff members actually will bring up YouTube videos of animals if they know a participant really likes a certain kind of animal to kind of make the experience a little bit fun. We have claim pages. We actually made these glitter jars that people can shake and watch the glitter settle and then take deep breaths as the glitter is settling. And so we have lots of things in our office that can make people feel supported and celebrate every single step. We recognize that even filling out the releases of information or that authorized representative form is a step for people, and so we do lots of aims and incentives and just celebrate with people those victories. The next goal is trustworthiness and transparency, and we know that if someone has experienced a lot of trauma, their boundaries have always probably been violated, and they may not know or have a difficult time understanding the roles of people in their lives. And so if you're helping someone get an income, you want to be very clear about your role in their life because you're going to be getting a lot of information and you have a lot of responsibility. So from the start, we give lots of opportunities for information to be learned. So we had Social Security come out and do info sessions so people can hear about Social Security benefits, not just from our staff. We also have taken people to the Social Security office just so they could ask questions and give them births. We want everyone to feel like they have as much information as possible. We also clearly explain every step of the process and everyone's role in it, and our Health Services Department helps with getting documents, and so we make sure that we are talking about all of those things. And we explain the positive and negatives of applying for benefits for people. So one thing that we do is we want to have a conversation with people recognizing that sometimes getting benefits is a good thing for them, but also sometimes it can be scary. It can be a trigger, especially if someone has a history of substance use or has been able to manage their money in the past. And so we want to let them talk about all of that. So we attached a document. It's a motivational interviewing worksheet. It's called the Decisional Balance. And it's a fancy pros and cons list that goes through the pros and cons of making a change or letting stay the same. And I think it's a great way to facilitate those conversations about benefits. So that is there for you to use. So the next principle is peer support. And we think it's very important that we are honoring the fact that our participants are the experts in their own lives, and we want them to have the opportunity to share information. So have forums where participants who've gotten benefits can share their stories of the process. And also we want to give every opportunity for our participants to tell us about their life, to educate us. They're the experts and we're not. The next, collaboration and mutuality. We are entering into these applications. We want to make sure that everything is a partnership and there's every opportunity for autonomy to be shared. So some things that we've done is give our participants the opportunity and the option to cancel an application anywhere in the process and to tell them that from the beginning. So one of the very first applications that I did with someone, I was so excited when they made this step, and then we had our phone application scheduled, an appointment, and I got to work, and they canceled. And not only did they decide they didn't want to do it, but they wanted me to call Social Security and tell them that we were withdrawing their application. And it was devastating for me. I had so hopes for this person in this application, and we did it. And then I told them I would be there for them if they ever wanted to do it again or not. And then I went in my office and had a few moments myself because it was a hard day. But then 3 months later, they came back and said they wanted to reapply. And so I don't know if that would have happened if I wouldn't have responded as openly from the beginning. I think the biggest thing, and I cannot stress this enough, are really motivational interviewing skills, because it really stops our staff from giving advice, and instead it allows us to guide conversations. Those core skills, the open-ended questions, affirmations, reflections, and summaries, really guide most of the discussions we have around benefits. And open-ended questions also allows us to ask less and hear more narrative, more story that will give us a better idea of what someone's really experiencing. Empowerment, voice, and choice. Traumatic experiences often involve someone's voice being taken away or their power being taken away. And then if someone's finally applying for benefits, that is an incredibly vulnerable experience. And they can easily feel like they're losing that power all over again. And so some things that we really try to do are explore the meaning of those benefits for people, the positive and the negative. And we already talked about the decisional balance. But most of the benefits, sometimes it's having conversations with people about the meaning of disability. That's usually the biggest thing I hear over and over again, are participants not wanting to apply because they're afraid of what it would mean to have a label assigned to them. And so shouldn't be afraid of those conversations, but let people talk about it. And also, you can even do a decisional balance around those conversations. A way to use that decisional balance is to fill it with someone, have them give all of the pieces, and then circle the things that are the most important to them. Because it may look like one side has a lot more things than the other, but if one column in there has one thing in it and that is the most important thing to someone, you want to know that as you move forward. So we also want to make sure our participants don't feel like they have to do anything they aren't comfortable with to start their application, see a doctor they don't want to see, have a treatment they don't want to have. And one of the biggest things about trauma-informed care, we spend a lot of time talking about triggers. We don't spend as much time talking about skills, and I think that's the most important piece. Is we want to see people heal and recover. And so in everything that you're doing, trying to find small ways that you can infuse your interventions with these skill-building activities. Simple things like breathing exercises, seconds breathing in, hold it 4 seconds, breathe out for 4 seconds, hold it for 4 seconds. Techniques, simple things like, okay, this is a lot. Let's get into this room. What are 4 things you see? What are 4 things you can touch? What are 4 things you hear right now? These things that people can do on their own. Also, self-care plans, we do with our staff, but we also can do them with our participants, sitting down and saying, this is going to be a hard period of time. What do you need? The last principle is the cultural, historical, and gender issues. And I've already talked a little bit about how we view gender and homelessness here. We really have to see everything through this larger systematic lens of oppression. And so when you're helping someone with this process, recognizing that everyone is impacted by this oppressive world in which we live in. And some of our participants are experiencing traumas more than others based on their identities. And you want to think about what those additional barriers are and give people the opportunity to tell you what they are in their words and validate that. And then figure out how you can use your privilege just as a social service provider to advocate for them and minimize those barriers. 6 principles. But as we're doing all of this and talking about best practice, we also recognize that a lot of this is about absorbing the pain of others, listening to people's stories of trauma, and helping them heal also means that we have to have room within ourselves to hold those things that they share. So I think for every provider, we have to figure out, because it's different for everyone, what makes space for you, and how to have daily practice. Self a lot of times doesn't have to be huge, but we often set huge goals for ourselves, just like we do for our participants. And so stepping back and saying, what is a meaningful step that I can do? Because I myself, I'll be like, I'm going to go to the gym 5 days a week. And then if I skip a day, then I'm like, oh, screw it. It doesn't, and then I stop everything. So think about the small things you can do every day. Can you do a breathing exercise for 5 minutes every day? Can you sit down at the end of the day and make a list of things you let go of? And recognizing your signs of burnout and hopelessness and seeking support. Whenever I'm not feeling hopeful, I know it's time to take some time off. And we also let our staff find creative ways to do the MSR and all of that work. So sometimes that means doing work from home, listening to music while they're doing it, taking lots of breaks. So that is an important piece as well. Now I'm going to hand things off to Lenny, my coworker, who will talk about some specific cases that she's worked on and some of the challenges.
Kim. So good afternoon, everyone. I'm Miletti Marsh, and I am a case manager at Deborahs Place, and I actually work at the building that was pictured on the first slide when Kim was talking about who we are at Deborahs Place. So, and yes, I have been SOAR trained. So I have a couple of vignettes here that talk about SOAR applicants who were not able to really talk about their mental health issues early in the disability determination process or even at all. The first vignette I'm going to talk about SS, initials, of course, for confidentiality. So, SS decided she wanted to apply for benefits for physical issues, leg and swelling. And that is actually exactly how we filled out the 368, the disability report. Nothing about mental health issues was included in that. It wasn't until we got to the medical summary report where I put in our observations and of her signs and symptoms that we observed of mental health issues that like significant issues of impairment that kept her from keeping a job. It does say this on the slide, but she did have her consultative exam, and by luck I was able to go in the office space with her. And I think the ending physician was able to see the mental health issues and I think requested another exam. And her claim was awarded, no appeal or anything needed. So that went well. The next case didn't have the outcome that we would have hoped for, but it still is, I think, a really good learning. It has learning things in here for me and for all of us. AG, her initial SOAR application included a lot of medical records showing a long history of it admits for seizure activity, so over a long period of time and at multiple hospitals. It was quite the thing getting all these records. So her initial claim was denied. I spent more time with her and more time delving into her MSR. It became clear to me that her claim might be strengthened by including some of the behavioral health issues, the signs and symptoms that I observed and that were sometimes noted in hospital records. She was not on board with this for the purpose of turning the focus into more psychiatric mental health. Her appeal was denied, and she decided to do other things. I'll talk more about that shortly. The vignette is an applicant that Ken and I worked on together, SM. She had a serious cardiovascular issue, but she was also quite fearful and anxious. I had known her for a period of years and was, quite to the point of paranoia. Like she would some take turns being paranoid about Kim or me. So there's that. She didn't have a formal mental health diagnosis, and she decided to apply based on medical issues only. She was so fearful that she could not even attend her both CEs that were scheduled for her. However, she was awarded her disability, and I believe on the strength of the contents of her hospitalization records for those medical issues. I really want to talk about the importance of the medical summary report in collaboration with the applicant. I see the medical summary report as a way to paint an overall picture of the applicant, no matter which reason they choose to apply, whether it's medical or psychiatric, because I can show how that I see and observe kind of give overall picture to how they're not able to work, how they're not able to sustain employment, and why they need benefits. I want to highlight the impact of their early experiences, particularly traumatic events, and how it impacts their day-to-day functioning, and obviously why they can't work and why they should get benefits. I think I can get to a very good medical summary report without that relationship piece that Kim was talking about earlier, without building that rapport, trust, improving myself to be a reliable and dependable practitioner who does what she says and is responsive to the applicant's goals and wishes. And so this is what I've learned, the importance of the collaboration in the SOAR process. So, I'm going to talk quickly about a case that's not in the slides here, SJ. And she shared with me some early traumatic experiences, which she told me she had never told anybody else and had kind of forgotten about them until now. And I made it clear that I'm using this information for the purpose of the medical summary report and how it's keeping her from working now, kind of keeping her from, not use a catchphrase, but just, being all that she can be. And was why I was asking this. Because of that information that she was very brave and willing to share with me, I felt I wrote a very good medical summary report. I think that was probably one of the most comprehensive and strong ones I've ever written. And the sad thing was that it was initially denied, and the appeal was denied, and she decided to go with an attorney for the hearing step. Until the MSR was not for nothing. So talking more about AG with her claim, how this didn't work out so well is I think I ever really had her complete collaboration and buy-in in terms of turning the focus to more psychiatric when I saw that the route with seizures and the medical was not panning out, that using psychiatric would be a better focus. So she said yes, but I don't think that she really was on board with this. And that was an important piece for me to recognize, because then when I began to delve into the pieces of the MSR, I could not really get a clear picture from her. Another thing I've learned for Kim is that when we do these medical reports to really work with an applicant and ask them, think about your stay, what it's like for you. Are you able to get out of bed? What does the whole day look like? What are you not able to do? What do you end up doing? So really kind of going, blow by blow, the nitty-gritty of what the worst day that you experience looks like for you. And I think asking her that question in several different ways on several different occasions never really materialized for us. I also wonder if she could imagine how there wouldn't be a case without seizures, which of course I put in the part. I'm not going to ignore all those, but how disability determination services would have not used those and why they would need extra symptoms like the mental health functioning that I saw. So I learned a lot from that particular case. And so now back over to Pam.
Thank you, Eleni and Kim, for sharing your experiences and how you, as SOAR providers, have been able to really, provide trauma-informed care to really pay attention to the needs of SOAR applicants. So thank you so much. Now we're just going to just spend a minute or two to just remind folks that Social Security has, as of the mid-January, just trying to change the slide. Mid-January, Social Security went into effect new mental health disorder listings, and one brand new one is a listing on trauma and stressor-related disorders. So since this was just recently instituted, we don't really know the effects yet. We may just start seeing some SOAR applications which have been awarded based on this listing. We don't know yet, but as you work with applicants and discover, as Lisa said, maybe some of the underlying signs and symptoms that you find, it may very well be that the individual may meet the listing for trauma. So we want you to, you can take a look at the entire listing by clicking the link below. That'll take you to the blue book, the listings of impairments, and then you'll come to the 12.15. Take a look at that, and again, as you meet with your applicant, you may see that, hey, these symptoms could be, coming from an actual trauma diagnosis. So maybe you may want to refer the individual for an evaluation if you see that. So you may want to take a look at it and see how you can help the individual be awarded based on this listing. Under this listing, Lisa talked a little bit about post-traumatic stress disorder. So this is where you will find PTSD under the new listing. So you will want to be aware of that as you will have many applicants who come to you with that diagnosis. So as you look through the listing, you may just find that they hit all the requirements for that. So definitely take a look at that too. And again, as Lisa talked about, the traumatic brain injury listing would not be under the new 12.15 listing. So we have plenty of time for questions. So in order to ask a question, we ask that you go to the Q&A panel on the lower right-hand screen and type your question into that panel. So underneath the participant tab. So take some questions that way. And we just want to remind you that the materials are available for download on the SOAR website under webinar. If you go there, you can download the materials for that. And I just wanted to let you know that one of the handouts we have is from the Gain Center here where Lisa works. So you'll see this handout which has the definition of trauma, the 10 principles of being trauma-informed, and also SAMHSA's key principles of the trauma-informed approach. So this will be a very handy document to have as you work with applicants, just to remind yourself of some of the key principles so that you can make sure that you're providing services in the most trauma-informed manner. So that will be available for you on the SOAR website. There. Okay. Remember to ask your question in the Q&A panel. Question in there. So this is, we don't have a question, but we have a comment. A couple of comments here that folks really did enjoy the presentation on trauma. So thank you for that. We appreciate that. Here's a question that we have. How do you convince or ask a client to go with the mental health side versus the physical side if they deny having any mental impairment? And I think that this question does come up often, where the individual may be applying for disability benefit based on back pain, but lack insight into any mental health disorders that they have. This question, I'm going to ask Eleni or even Kim to talk about that, because I know Eleni, one of her did discuss an individual that did not feel ready to go with a mental health impairment, possibly because there was no diagnosis, never evaluated. Eleni, do you have any suggestions on how to approach a applicant who might want to, with a mental health treatment, and what you did about that to help them see how important it was to their claim?
Oh, yes, this is Eleni, and I think it's always a dicey situation because you have to approach this individually, just on what you know about the applicant and your relationship with the applicant, how amenable they'd be to any suggestions that you have to make. I think in the case with SS that I talked about was I see that mental health issues was going to be the strongest case. I think everybody that who worked with her could see that, but I thought the only route to getting the claim off the ground would be to start where she was at and do the medical route, and all the way maybe evidence to the mental health functioning would get picked up. And that's precisely what happened, in that I got to go to the exam when it was ordered, and not just wait in the waiting room. I was allowed to go in the exam room, and I think the doctor there asked all kinds of questions. I think did a physical exam, and her some questions, and the answers that she gave were just had nothing to do with the I think the questions that he asked. And to be honest, I make eye contact with him to say I think there's something else here, and he seemed to take my hint, and he said that I'm ordering another consultative exam, and he told her it was a mental health exam, and she said she didn't see the need for it, but I took her to that one, and on the strength of that, and I believe the report that Kim and I wrote together, she got her SSI. So there's something more to say about this too, and so I'm going to pass the baton over to her.
Thank you. So some other things just generally that we've done at our agency. One thing, we've obviously spent a lot of time here talking about trauma, and I use that in my conversations with participants. And I talk about how sometimes things that have happened to us have a lasting impact. And it doesn't mean that it's going to get in our way forever, but it does mean that it might make it challenging to work at the point in your life. And so we really normalize that and talk about how our brains are impacted by the things that we've been through, and that a lot of times is something that really helps people see that it isn't a label. It isn't that they're mentally ill. It's that they have been through things that have this lasting impact and are going to impact their lives at this period. So I talk a lot about the trauma of homelessness and the world in which we live. Another thing that we do is I'm really open about saying, just so you know, I really want to help you get your benefits. So when I am doing my letter of support to you, I'm going to report everything I see. And some of that is, some of your hard times that you've had as well. Are you okay with that? And disclosing that. But also when you're doing that MSR report, I'm an LCSW. I can technically diagnose anyone, but that's not the kind of social work I want to be. But I do talk about, does someone have a hard time sitting still for a long time? Does someone, have a hard time focusing? And I do make it all very, very measurable. And is that mental health or is that trauma? I don't really know, and that's not my role. My role is to communicate how someone's work experience could be impacted by what's going on with them right now. And then we've also had a lot of luck with people having consultative exams where, the doctor will ask questions and people will make some pretty delusional statements about, we had someone who applied for leg pain and then they went into their appointment and they said that a shadow was, punching them in the leg, and the doctor picked up on that right away and ordered another exam. And one thing, we have a consulting psychiatrist that we've worked with at Deborahs Place internally, and that has been great because a lot of times our participants have known them and seen them and they trust them, and we will say, how do you feel about sitting down with Doc Liz for 10 minutes just to talk about your experiences? And she's very flexible and has been willing to fill out those forms. So, sometimes it's, can you use your internal resources? Do you have any partnerships with any providers that could come on site? So just being creative about that. So I think that's it.
Thanks, Kim and Eleni, for answering that. I think that you provided some thought, to help the, other SOAR providers out there, better MSRs and include the information that you mentioned. Here's a question that came in. How do you let a SOAR applicant know that he was denied when he was very hopeful and has a very severe mental illness? And I think that's tough for any of us who have filed applications and received denials for claims that we knew had very strong merit and should have been awarded. It is really hard. I'll ask Eleni, I know you have experience filing SOAR applicants, and you did mention that you did have a denial. Do you want to talk about maybe what words you said to the applicant who was denied?
Okay. Well, this is Eleni again. So, again, this goes to the kind of the honesty and transparency principle that that Kim talked about earlier, and letting the applicant know that this process can take a long time. Sometimes it can be long, several months. So it's kind of like the thing I learned in the SOAR training, under promise and over deliver. So under promise in terms of a long length of time, and doing more than you are going to do. I think also letting the applicant know that there's always the chance that for what reason sometimes the claim will be turned down, and as soon as we learn that, we can work as fast as we can to appeal it and get more evidence in and just keep going, because persistence pays off. And also telling applicant never give up hope, just keep working in there and having hope for the applicant when they have none for themselves, feeling pretty hopeless. I think practically, if you're in the appointment of representative, depending on what housing situation the applicant's in, they may get the letter at the same time. So you get your notification of the denial, say, and so, you'll get the unhappy news together. And so it's not something that you have to do the applicant, unless they've asked that you check their mail for them. This could be something that you talk about in the opening conversations, that how do you handle this going forward? Just in the case that we get a denial, you want to handle it. Like, very often people will say, I want to appeal. I want to keep going. And offering options as well, even though I know the SOAR process is designed to not involved ability attorney at the initial steps, but make it clear that if this is an option that they want, that you will support them with this. It's about not dissuading them from options or things like that. If they decide that this is what they want to do, then that this is fine. So, anything you want to add, Kim? Okay. Well, thank you.
Honey, I think your advice was spot on. I think having that conversation early really can be very helpful to the individual, so as to not lose hope that this is a process, that an appeal, something that you go forward and hopefully turn that into an allowance. But again, don't overpromise, right, that you're doing the best you can with gathering all the medical documentation. So I think that, being honest and letting the individual know that you've done the best that you can, and that through the appeal you can also request to look at file to see how close the individual was to an allowance and what you can do to bolster the case. So I think honesty really is the best policy in having that conversation early on, so that if there is a denial, that it's something that, that does happen and a possibility. Here is actually a comment that, or a strategy or a solution for an individual that did not want to go to a medical or psychological evaluation, probably one of the consultative exams, a CE. So Mindy says, we had a client that would not see any medical or psychological evaluators. However, she agreed to let us video her during an intake reevaluation with her caseworker. We showed that video to a doctor who was willing to write an observation of her behavior, and then coordinated her behaviors with a diagnosis. I think that is great, and if that worked for you, it would be great to have some of the details of that. And if you have a redacted copy of the letter that the doctor wrote, it would be really helpful to see if you want to send it our way. Again, as long as that doctor did give a diagnosis and could write up, all of the observations that he sees, that was enough for DDS. Sounds like, to be able to make a decision. So thanks for that. Thanks for sharing that. That could be a good alternative for folks to pursue. Well, I think that's about it with questions. Feel free to, if you have questions that you think of, please send them our way. We would love to, hear any questions or comments that you have, and we'll pass them along to the presenters. And again, I want to thank Dr. Callahan, Kim Davidson, and Miletti Marsh for putting together such informative presentations. We really thank you for sharing this whole information. So again, the webinar will be posted on our website, the SOAR website, in about a week, and you'll be able to get the presentation, listen to the audio, and get the handouts that way. So I just, again, want to thank you for joining us, and have a good rest of the day.